to give me yet another chance to moderate the session with my friends. Today I was a bit occupied at home, but still I made it a point that I have to attend my duty to attend and to moderate the session. My pleasant duty to introduce Dr. Suparno Chakraborti. He's having, I think, second talk with us, and he is alumni from PGI Chandigarh. I interacted with him just a few minutes back. He informed me that he is one of the stalwarts in India with Dr. Sarita, Jaiswal, their team. They were the first to start haploidentical bone marrow transplant in India. This was in 2010, when Salman Khan also was in limelight coordinating bone marrow transplant for others. So this is such a noble cause, and he is in a very innovative field, which is ever flourishing and advancing. Many things have changed from initial to present day. So he is with Dharamshila, and he has done close to 250 haploidentical bone marrow transplants. Big hand to him. My special interest is with thalassemia major, which goes to Dr. Sarita, which she will take care in her talk. So I am very keen because I have a few patients which I have been searching whom to refer. Now I will find the place and I will put the name. So I won't take much time to introduce Dr. Suparno Chakraborti. He has so many national and international papers and very affluent in his field. मैं सिर्फ बोन मैरो के बारे में 2 मिनट लेना चाहता हूँ। हमने आजकल सबके आसपास बिल्डिंग बन रही होती है, तो आरसीसी पिलर्स बन रहे होते हैं। पहले एक आयरन का एक फॉर्मेट बनता है जिसमें आप उसको ढांचा कह दो, फिर उसमें सीमेंट और कंक्रीट उसका जो डालते हैं, ऐसा बोन मैरो होता है। तो बोन मैरो इन द बोन इज लाइक दैट reinforced concrete and cement. At birth it is only red, and as we grow it starts turning to yellow also. And yellow is not very useful for our purpose for transplant. We want red only, but in adults we have close to 50% in red and 50% in white, in yellow. In emergency, yellow can also go into red. So, Nobel Prize for bone marrow transplant in 1956, when I was born, was given to E.D. Thomas. He was first to start it. So, with this introduction on bone marrow, I call Dr. Suparno.
Just a minute, sir. Just a minute, sir. And I also acknowledge the presence of Dr. Sinha, President South Delhi IMA, sir. So, big hands for Dr. I have given the noble duty of introducing all the 3 speakers to my main moderator, Dr. M L Kalra, sir. But it was my due desire that we also involve Dr. A S Nigam, sir, and Dr. Savita Sachdeva, ma'am, sir. We will have your useful inputs and insights as we go along in the CME. We will go ahead. Naresh, number of CME, the CME today?
9.
Friends, I am honored to say that with your cooperation and continued support, we have been able to achieve 940. Friends, ladies and gentlemen, welcome to uninterrupted, continuous, every single Wednesday for last 20 years, CME number 940.
So good evening, seniors, friends and colleagues. When we were going around the tables, we just felt one thing. You know what is that one thing? That's inspiration. That you people have gathered today to listen to something which you think can make even 0.001% difference in our, the way we look at the world, the way we practice. The reason I'm saying this is that modern medicine, which we all practice, is around 100 years old. And the wisdom we have gained in terms of the absolute human biology is not more than 0.0001%. This acknowledgement has to be made at the outset by the teachers, by the students, by the practitioners of medicine. And with that humility, we start the journey. So here you see who was just spoken about, Professor Donald Thomas, who started his career after residency. He started as an assistant professor at Seattle Fred Hutch Cancer Center in 1960s, early 60s. At that time, bone marrow transplantation, 200 attempts were made according to Borti, who published an article in Annals of Internal Medicine, who said that it's a done thing, it's not possible. And that was enough to put bone marrow transplant in its coffin forever. But this gentleman had a different plan. He said that we have worked in mice, we have tried in humans, but it didn't work. So let's try it in something else, which are the creature you see, the man's best friend on the left, the canines. And to cut the long story short, through the series of his experiments, he established 3 basic principles of doing bone marrow transplantation through canine work. Mind you, very few disciplines or organ-related work has developed in canines. Bone marrow transplant is unique in that way. What was established is that first thing, to get someone else's bone marrow into another person, you need to condition the patient, which means that you have to prepare the body. And how do you prepare the body? He established that you need high dose of chemotherapy and radiation therapy to do that. The second principle was that the donor who will donate the bone marrow or the bone marrow stem cells to the patient has to be compatible or HLA matched with the patient. That's an absolute prerequisite. HLA is a signature in every human cell. So it's like a bank teller. If the signature matches, you get the cash. If it doesn't match, you don't. And the third thing is, even after that, it might not bring the desired result in terms of living happily ever after. Why I'm saying that even if the patient accepts the bone marrow, the cells in the bone marrow might go and cause trouble in the patient, which is called graft versus host disease. So you need something called a graft versus host disease prophylaxis. But graft versus host disease was soon recognized as not one of the most unwanted things, but also essential in malignant diseases, because through graft versus host disease you manage to eliminate leukemia, which a bad leukemia, you manage to eliminate it. How and why I'll come to that soon. And in the 1990s, 3 people, Megan Sykes, Shimon Slavin from Israel, and Hansi Kohl from Germany. Individually, they showed that although Donald Thomas established the principle that you need high dose of chemotherapy and radiation for conditioning to do bone marrow transplantation, that's not essential. You can do with much less, which is called non-myeloablative or reduced intensity conditioning, which forms the crux of bone marrow transplantation today. And at the same time, they showed that if a disease comes back after bone marrow transplantation, in many of the cases, you can simply take white cells from the donor and give it to the patient and induce a remission again in the patient. So this proved that, okay, so how are we curing the cancer and leukemia after bone marrow transplantation? The initial thought was it was through the conditioning. High dose of chemotherapy and radiotherapy, which the standard dose can't, the high dose can. But Shimon Slavin stood against it and said that no amount of chemotherapy or radiotherapy can eliminate the last cancer cell, because cancer cells are killed in lots and you cannot eliminate the last cancer cell. So what do you need to kill the last cancer cell? So it's the same thing which prevents cancer from happening in the body. The same thing kills the last cancer cell, which is the immune system. So if we go, I'll come back to that because that's the topic today. But someone was asking, can an unrelated donor donate? Now, that's an interesting question. That was a question which Donald Thomas asked in the 1970s, end of 70s, that only 20% of the patients have a HLA matched family donor. So what happens to the other 80%? So by sort of, a series of randomness, they found that unrelated person is matched to another unrelated person in all the 6 or 8 HLAs that were tested that. So they thought that why don't we collect a repository or create a registry of just random normal donors and see if we can get donors for patients from that registry. And that was what it was, an unrelated donor registry where people volunteered. I'm there, just take me in. So a computerized registry was created which now exceeds 10 million, where if you go to the next slide, but you find that this is an old slide. And I'm not a great slide maker, so I've not updated it. 80% of the Caucasians, 80% of the Caucasians means people of European descent, get a matched unrelated donor from that registry. And from that registry, only 10 to 20% of Indians would ever get a match. So what do you do? Can you do a HLA mismatched unrelated donor transplantation? And if we go to the next slide, we'll see that the more the mismatch, the worse the outcome. So that was established. That you need HLA match to be as stringent as possible to get the best possible results. So we are back to square one. So 20% have a HLA match and another 10% might get an unrelated donor. Then go to the next slide. Yes, and this is a beautiful thing. I'll talk about it for 2 minutes because this is science. This is pure science. This is a British gentleman called Moderator with 2 of his students, Billingham and Brent. Billingham, Brent, Moderator. This is Brent, this is Billingham, and this is Moderator himself. Moderator, by the way, won a Nobel Prize largely because he was British in a few years. But the work they did was phenomenal. If we go to the next slide. So, and previous slide, please. So, not this. So, there was organization for science in UK who were funding to see, this was a veterinary science department, who were seeing that what happens if one animal is grafted from another animal in terms of skin graft. It never happened, it never fructified. So what these three gentlemen did was said that what if we introduce small amount of cells? These were mice experiments, these were chicken experiments, mind you. So what if we take an adult chicken, take some cells from it and introduce into a fertilizing egg of another hen and see what happens. So to their utter surprise, this was a freak experiment, this was just a hypothesis out of conjecture. What they found was that when this chick was born and grown into a hen, if they took the skin of the hen or the cock who was used for the cell inoculation into that fertilized egg from which this chicken grew, it accepted the graft. So they hypothesized that if in utero any animal is introduced to a foreign cell, a foreign antigen, they don't reject it, they tolerize themselves to it. And what is a better example, if you go to the next slide, than pregnancy itself, where the mother and the father are naturally HLA mismatched in 99% of cases. Yet the mother accepts a fetus or an embryo which is mismatched with the mother in half of the cases. So pregnancy is the best example where a foreign antigen introduced in utero is tolerized by the mother, and the mother's mismatched antigens are tolerized by the fetus. So based on this principle was born the principle of haploidentical or half-matched family donor transplantation. Now, this is not possible with an unrelated donor transplantation, unless it's a lost brother from the same mother. It has to be linked to the mother and the child in utero phenomenon. So only then a haploidentical transplantation or a half-matched HLA donor transplantation is possible. We inherit one half of HLA from the father, one half from the mother. So we are naturally half-matched with the parents. We are naturally half-matched with the children. And 90% of the time, if not fully matched, will be half-matched with the siblings. So think of it. When you are talking a full HLA match, only 20% chance. Mushkil say you get one donor in the family. And that's it. You have to take that donor, good, bad or ugly. If you want to do a transplant, this is what you have, now take it or leave it. But when you are doing a half-match transplantation, if you think that you can do a half-match transplantation, if you think half-match transplantation is possible, then you have plenty of donors in the family. It's a unique situation, a Huzpur situation we faced, where there might be 2, there might be 4, there might be 6, there might be 8 such donors in the family. And then you are left with a choice out of plenty. No, it's not this. But doing a half-match transplantation this side, whatever I told you was not easy. It took 20 years for someone to actually materialize it, and this was my good friend Frank Barbosa. He's 5 years older to me, and he is from Perugia, Italy, who first made this into a reality. And in the next slide, please. For the first time, we realized that there are cells outside the T cells. If you go back to the previous slide. So what they did in this case was, that they condition the patient intensely to get rid of the immune system, get rid of the bone marrow cells, get rid of the cancer cells. But more importantly, they got rid of the T cells from the donor bone marrow. Because the T cells are going to cause graft versus host disease. And in case of half-match transplantation, that's fatal. So they got rid of T cells. But what we knew by that time was that T cells were essential to cause graft versus leukemia effect. And in bad leukemia, if you do not give T cells, they're going to all relapse. But what the group from Italy showed is that, especially in acute myeloid leukemia, the relapse rate was very low. And go to the next slide, please. And that was because of what I'm going to show you next, the natural killer cells. So what are natural killer cells? And this is the cell which has sort of mesmerized me for the last 20 years. And this is what I've been trying to work in the last 20 years. And I have passed it on to Dr. Sarita to take it forward. Unfortunately, in India, very little work is taking place in NK cells. The work on NK cells, particularly in the field of transplant, has largely emanated from Italy, some parts of Germany, Netherlands, and some parts of US. It's still limited. So what are NK cells? We go to next. Contrary to the T cells, these are thought to be cells of the innate immune system. Now there are two parts of the immune system. One is the innate, which do not need any priming. If you face them with a foreign antigen, they will do their job. And the adaptive immune system is a very fine-tuned, advanced, sophisticated system where each cell will identify a particular antigen and nothing else. So an antigen will, a T cell will identify a particular serotype of rhinovirus and not the other serotype. It will identify a particular variant of COVID and not the other. So that is how fine-tuned they are. So adaptive immune system is like a precision missile. It will go and hit the sarcola base and nothing else. Whereas the innate immune systems are thought to be, they are going to take everything that comes their way. So they are not going to be specific. And next slide, please. The NK cells, as time moved on, we realized that they're very different from T cells. How are they different? Go to the next slide first. So see, the T cells would first identify the antigen that it's supposed to identify. So they are constantly trafficking through the body. In the lymph nodes, they pass on for a few sort of 10-15 seconds, and in that 10-15 seconds, if they find the necessary antigen that they are supposed to recognize, they will stick to it. But the nature has made our bodies like this, that that's not enough. Because if that was enough, that would be catastrophic. Why I'm saying this? Because T cell is like one of the strongest nuclear bombs in the human body we possess. We have seen it during COVID that if you leave the T cells to themselves uncontrolled, it can destroy a human body. The inflammation it would cause. So it needs a second step called the co-stimulation, where the antigen-presenting cells have certain receptors, the T cells have certain ligands and they have certain receptors. So the binding, it's called the step of co-stimulation. So these two steps together will result in T cell activation, and T cell activation then would take care of the necessary pathogen, because these are all pathogen directed. Mind you, the human immune system is born out of the necessity to prevent the billions of pathogens around us from killing ourselves. That's the job of the human immune system. So everything is with reference to pathogens. So, at the same time, the virus has lived 1 million years before us. They will live for 1 billion years after us. So how do they survive? When the humans came into the system, or even the bacteria came into the system, viruses had to find a way to survive. They are the longest surviving species on the face of the earth. So MHC molecule, the MHC class 1 molecule are expressed in every human cell. Now any virus particle antigen will attach to it, will be recognized by T cells, and they will be destroyed. The cell will be destroyed. Now what about the virus? The virus doesn't exist by themselves. They go into the cells, incorporate themselves into the cell, and they multiply inside the cell. That is how the viruses survive. And one of the things they do to survive is they down-regulate the expression of this molecule so that T cells cannot kill them. So that is how a viral infection sustains in the human body. But nature or God gave us something to tackle it. What was it? The natural killer cells. Let me stay there. So the natural killer cells. Now natural killer cells are normally in a state of activation. They are constantly in a state of activation like a hyperactive child. They have to be kept under inhibition. And who keeps them under inhibition? It is the MHC class 1 molecule which keeps them under inhibition. So when the virus is trying to prevent itself from getting killed by the T cells by down-regulating MHC class 1, the NK cells are losing their inhibition and they are now going to attack. So we have a two-pronged system in the human body to take care of pathogens. And the same applies to cancer. Cancer is a pathogen which is created within the human body. The same way a MHC class 1 would be down-regulated and NK cells would take over. So we understood the primacy of the NK cells through the work of the Italian group, where they showed that these NK cells are essential for killing of the leukemia cells. I'm not getting into the details. It is through a very sort of apparently complicated process. I don't have the time to say that. Go to the next slide, please. So what NK cells do is, through a process, what they call docking with the target cells, they dock, they release something called perforin, and in the same process of docking, they will release interferon, which will cause inflammation. So it will either be an inflammatory killing of the cell, or through docking, they will release perforin, which will cause pores inside the target cells, through which the enzyme molecules will go in and cause apoptosis of the cells. So this is how the killing actually takes place. And after transplantation, natural killer cells are the first cells to come up in the system. And when you do not give T cells with a graft, these NK cells, if they have the right predisposition, they will take care of the leukemia. But what was further recognized was that it's not that every NK cell will do the same job. We are genetically endowed to have certain pattern of NK cell activating receptors and inhibitory receptors, which are called haplotype A and haplotype B. Go to the next slide, please. So if we have a haplotype B, it gives us an advantage over in patients with leukemia. Means they have a better ability to kill the leukemia cells. And for a long time, people have tried to work on these NK cells, how to isolate them, how to expand them, and how to use them in clinical practice to induce anti-leukemia effect. And the next few slides are just, if you just go through them. There are many examples of how these cells have been used to, just go through them. There are a lot of them. But we had a different, serendipitous, means coincidental encounter with these cells when we started our journey of haploidentical transplantation. Go to the next slide, please. So, when we first started doing haploidentical transplants, We could not use high dose conditioning because those patients were very sick. And although initially we had initial success, which is engraftment, lack of GVHD, first 10 patients. To the next slide, please. And we showed that, it is the reconstitution of NK cells in the body of the patient after transplantation which matters at the end of the day. And subsequently, go to the next slide and the next slide, and you will see that we are sort of pioneers of using this molecule called abatacept, which actually was initially used for blocking T cells in patients of autoimmune disorders. We use this for the first time in transplantation for GVHD prophylaxis, to prevent GVHD, to enhance engraftment. And what we found is that that's the job it's doing brilliantly in combination with post-transplantation cyclophosphamide. And, abatacept was initially tried in clinical trials for solid organ transplants to prevent rejection. It was found that although it did engraft initially, all the patients rejected. And they found that it was because abatacept could not inhibit the NK cells. I'll ask you to just listen carefully over here. This drug was thrown into the dustbin for solid organ transplants because it could not prevent rejection. And the rejection was mediated through not the T cells but the NK cells. So we thought that why not use this in bone marrow transplantation to promote an anti-leukemia effect. How? If we are giving donor lymphocytes which contains both T cells and NK cells, T cells being 90%, NK cells being 10%. So what we did was give abatacept along with donor lymphocytes very early after transplant, and what we saw was that incurable leukemia were getting cured. And what we showed over here is that if we are just giving donor lymphocyte infusions versus when we were giving it with abatacept, the results were far superior but without causing graft versus host disease. And we further found that there was a group of NK cells which behaved like T cells without causing graft versus host disease. They were called adaptive NK cells. And we showed through various experiments at that time that these cells, if they reconstituted early, would result in reduced relapse without increasing graft versus host disease. And mind you, what was the trick of these cells? Or very beautiful how nature does these things. So these cells do not naturally come up in our body. They are triggered by cytomegalovirus infection. So if we get exposed to cytomegalovirus, which 50% of the Western people don't mind, up to the age of 50, they are not exposed to cytomegalovirus, only 50% are. Whereas in India, 95% or more are exposed to cytomegalovirus by the age of 5 years. So 95% of Indians are endowed with these cells or adaptive NK cells, provided, next slide please, provided this particular gene which encodes for a receptor called NKG2C is intact, but genetically 30% of us, which we found through our study, have deleted one allele which is deleted of this particular gene, means they cannot produce sufficient amount of this particular receptor called NKG2C, which means that adequate amount of adaptive NK cells are not produced in these patients. And what we found that when such donors were used for transplantation, the incidence of acute graft versus host disease was higher, the incidence of the overall survival was lower, and more importantly what we found that, go to the next slide, so when we look at relapse, that actually what mattered was the amount of adaptive NK cells which the donor had. So with this background, Dr. Sarita took up a project to explore this particular phenomenon as to what is happening with agar-receptor NK cells 5 years time. And she will summarize what tremendous work has happened in the last 5 years to, for the first time in the world, to show something it has never seen. Over to Dr. Sarita.
I would just give it to Dr. Savita Sachdeva to introduce our second speaker.
Thank you, Dr. Chakraborti, for for making us understand the pathogenesis and the use of chemistry between T and NK cell. Now I invite Dr. Sarita Rani Jaiswal. Dr. Sarita is the program director, haplo-identical BMT and consultant in BMT and hematology at Dharamshila Hospital and Research Center. The CV is very, very impressive, but I will take only few points. Dr. Sarita, she has been awarded the ESH-EBMT scholarship for her work in haplo-identical BMT, and she is heading the research facilities program, one of its kind in India, with a dedicated patient care wing as well as the basic research facilities. She has done over 200 haplo-identical BMTs in the last 2.5 years, with an impressive outcome in most difficult cases of refractory leukemia, lymphoma and severe aplastic anemia, with a disease-free survival of over 70% in malignant cases and over 80% in non-malignant cases. Her major area of research is on post-transplant immunotherapy and prevention of GVHD following haplo-identical BMT. And she has over 50 international publication and presentation in the last 3 years. The group has recently started a clinical trial on haplo-identical BMT in thalassemia and sickle cell anemia. In addition, Dr. Sarita has major interest in management of acute leukemia in children and myeloproliferative disorders. She is affiliated to American Society of Blood and Bone Marrow Transplant, and she is also affiliated to American Society of Hematology, European Hematology Association and Asia Pacific Hematology Consortium. Welcome, Dr. Sarita.
First of all, thank you, ma'am, for such an excellent introduction, and I thank you all for presence, and I thank Dr. Chakraborti for making my discussion very easy, giving the detailed introduction of each and every part. So I'll just go to the presentation which was given by Professor Josu. He is a consultant hematologist and Director of Pediatric BMT Program, Imperial College London. So he is a head of EBMT Hemoglobinopathy Party worldwide. So, and I am also an active member where he has shown the way we do transplantation, and he has said in his discussion that we are copying Dr. Sarita Jaiswal, that whatever she has done. So I have just put, because 4 days back we had a similar place we had discussion about the thalassemia transplantation, where everyone has the query, how can your transplantation rate is successfully, how are you doing successfully? It's unbelievable. So that is why I have brought this just a small snippet. Just go ahead.
Both related and unrelated and mismatched donors is able to abolish any increased risk that might find of graft-versus disease. And let me acknowledge also that the use of abatacept within a PTC-wide platform does also come from India. And so we copied this from the work that Sarita Jaiswal did, and we have validated that related and unrelated donors, as you can see there, with excellent results.
So he has clearly said that we are talking
both related and unrelated,
have
and
to
mismatched.
understand that whatever years of hard work Dr. Chakraborti has done and our team has done, and no one has recognized this work in India.
I will just say something that we started this work in 2014, 2015, nearly a decade back, when this drug was nowhere in the scene for transplant. It was a drug for rheumatoid arthritis. We repurposed this drug, and in the process of doing so, we had, Dr. Sarita didn't go out much, so Dr. Sarita used to present the data everywhere. The Indian transplanters, the Indian scientists were never interested because they needed a Western validation. We need a Western validation for everything. Brahmos is good if the US tells it's good, isn't it? So you heard from the horse's mouth. What he said is that this comes from India. Newton did not say that his idea came from Kanakmuni or Pingala, but Joshua said that's the credit goes to him, that he has taken the idea from India. And if Mr. Modi is listening, he should know that this is a true Make in India project.
Wonderful, wonderful.
Very nice.
So thank you all. So this is our story, and I will just, because I am in the middle of this discussion and your dinner, so I'll try to finish everything in a very short time period. So I'll tell you what is the mechanistic pathway and what all we have done in the lab primarily. So we know that there are certain human malignant cells line which are extremely sensitive to NK cells. And one of those cell line is the human myeloid leukemia cell line, which is called K562, and we have used in our research purpose, and we have explored the cytotoxicity, which Dr. Chakraborti has told about the NK cell cytotoxicity with this particular cell line, and we have established there are certain models are available at the same time, but the most established that we have taken in our research is the NK cell is when we are incubating these cells with particular type of cytokines, because if you are taking NK cell and taking the leukemia cell and just incubating, we are not getting the answer. So what we need to do, we need to stimulate these NK cell and then proceed it further either with the abatacept or other cytokines, and that we did it. So I'm showing what is the effect of this abatacept on this NK cell cytotoxicity and the different experimental conditions. So to establish that, what we did that the first we have isolated these NK cells from where? From either from the PBSC, means peripheral blood cells, or from the we did the leukophoresis product as well. And then from these NK cells we stimulated the cells with certain cytokines, either IL-2, IL-15, or it's a combo of these, that the interleukin 12, 15 and 18, and we incubated these cells, and then after certain time like 72 hours and 7 days we have seen the cytotoxicity of this particular NK cells, and by effectiveness also we have seen the intracellular cytokine release in the form of interferon gamma and the perforin. So this is the basic lab work that we did to establish, yes, what is happening, what is the mechanistic pathway of this successful outcome which we have shown that. So what we found that after the 72 hours of incubation, whether we are taking 5:1 ratio or 1:1 ratio, means effector cells, that NK cells, and the target cells are the K562. So we are incubating these cells in the lab, and we found that there is significant with the addition of abatacept, there is an increased cytotoxicity whether we are taking the 5:1 ratio or 1:1 ratio of IL-2 with IL-2, IL-15, but not with the CIML, means cytokine-induced memory like NK cells, in which we have taken the 12, 15, 18. So similarly in 1:2, but at the same time when we extended our experiment from 72 hours to 7 days, we found that the IL-2 effectiveness has reduced, but with IL-15 it is maintained. So IL-15 maintained for the shorter as well as for the longer time period, and so at the same time we did what we did. We have seen that there are no cytokine, no individual cytokines or its combination were superior to each other with this experiment. You can see, however, when IL-15 showed maximum NK cell cytotoxicity in presence of a beta sept at all time period like 72 hours and the 7 days. Now coming to the second experiment, what we did there, we have seen the cytokine release. So one part is the cytotoxicity and other is the cytokine release of these cells, and these are just experiments where with a beta sept everything is significant. You are seeing that after 72 hours, not with the combo of these cells. So now the third thing we have done, that we have seen the impact of a beta sept prime donor lymphocyte infusion, which Dr. Chakraborti has seen that we were using a beta sept, and then after 12 hours later we were giving the donor lymphocyte infusion. So until day 20 we have taken the sample, and after giving the cells we have again compared with the non-DLI group, means a beta DLI and the a beta sept group as well, and similarly we have seen at a different time point what is the cytotoxicity and what is the cytokine release in the form of interferon gamma and perforin release. So this is the slide showing a beta sept DLI, like we are giving these DLI on day 21, 35 and 60. So we are comparing with the previous to giving these cells, and we have seen that there is cytotoxicity when a patient is receiving donor lymphocyte infusion as compared to only a beta sept. So these are the few experiments that we have done, and not only for this limited time period, we have shown that over a period of time like 1 year, 2 years. But interestingly, what was the remarkable, that the patient who relapsed had shown very little cytotoxicity. So the most left side, curves show that the patient who had a relapse, their NK cell did not show cytotoxicity. So the graph is showing in the lower range. Now, what was the fourth thing that we did? That is cytokine release in the form of interferon gamma and the perforin. So previously you have been told that the NK cell, they are identified by the CD3 negative, 56 positive. Now this NK cell has been subclassified as NKG2A cell, NKG2C, which is the adaptive NK cell. So we categorize it, and it is identified as a CD56 positive, NKG2C positive, but NKG2A negative cell. So this is a particular type of NK cell, and if you are doing in our experiment, if you are doing with the NK interferon gamma and perforin, what we have seen that compared to the other subtype, these particular cytotoxicity as well as the cytokine release, interferon gamma and perforin, was immensely better in the terms of there is a high cytotoxicity with this particular cells. So we have observed what we all observed, that the beta sept DLI was associated with enhanced and the sustained NK cell cytotoxicity, and it is with the NKG2C. 2C positive cell, not with the NKG2A positive cells. So this was the history. So now I'm coming to the patient's cell. So in that respect, what we have decided that we will choose the donor, because in a half match transplantation, for a patient, parents can be a donor, sibling can be a donor, as well as we are similarly transmitting to our children half 50% of antigen. So our children are also half matched with us. So there are lots of donors you have in your basket. So whom should we choose to get a better result? So in that respect, we have divided this group, the donor group, like into the 4 groups, like NKG2C particular cells. It has been expressed, the gene which express these particular cells in NKG KLRC2 genotype, that can be wild type or can be deleted type, and Dr. Chakraborti has explained. So we divided as per categorization, like wild type with ANK means adaptive NK cell high, similarly wild NK low, and the deletion, and in that respect we divided them into 4 groups, and then we tried to find out what is the most effective part. So in terms of overall survival, non-relapse mortality, relapse or acute GVHD, because these are the parameters which we look for transplantation. What is interesting over here, you will see that the patients who have been transplanted with a donor who have KLRC2 genotype of wild type with NKG2C, whether it is low or high doesn't matter, particularly for the acute graft versus host disease. They have very low incidence of acute GVHD, less than 3% means 2.6 or 1.6, as compared to who have the deletion variant of KLRC2. So that is 33 or 30%. Similarly, the overall non-relapse mortality and the relapse has particular group which has the more relapse, and these are the findings which we had incorporated in choosing a donor. And finally, we can say that the better overall survival, you should take the donor who has the more of ANK, adaptive NK cell percentage, higher adaptive NK cell, and with the KLRC2 of wild variant, which has the 90% survival. And we have also seen, as I have explained, the relapse patient who did not relapse, who has a better adaptive NK cell reconstitution post transplantation on day 30, 60, and 90. Who did not reconstituted these particular type of NK cell had a worse outcome in terms of relapse. And these are just the study, and don't want to waste your time. So these are the differential gene expression volcano plot we did to understand in the lab, and we have seen that they express particular type of gene in which the T cell regulatory pathway or T cell activating pathway, what is happening is down regulating, why is adaptive and down regulating the TH1M1 receptor pathway, so that is the tolerance and the less relapse. Now coming to the bends, the most important thing. So what is the gist of this talk is that we are lymphophorezing, then aliquoting in 3 aliquots, and then we are incubating with them with the IL-15 and beta cell. And then we have studied that these cells have better survival. And we are trying to make it patent as well, so that we can store them and we can infuse to them. And I am showing you a few of the snippets of the patients who had like this is a 28-year-old female who came in from the other place to get transplantation, but unfortunately when we did before transplantation, when we are doing the workup, we found that she had 56% of the blast, which is a leukemia cell, so no one can ever dare to take this patient for transplantation, but family had insisted us, so we took this patient for transplantation, and you can see that after transplantation, FLT3 mutation that becomes zero, and patients become out of disease. There was no disease. Similarly, there are 2-3 other patient snippets are there. I am just skipping these slides. Don't want you to waste. And finally, I thank and I acknowledge my team.
I would like you to please come here, ma'am. Vijay Light Silano. I think we had 2 wonderful presentations. I was hoping for third from Dr. Mahek, but I was told that there is no presentation. We'll wait for that for the next event, for your presentation. Because I was asking Dr. A S Nigam sir that you have to introduce the third speaker, and I was told that she doesn't have a presentation. But your presence is acknowledged as much as the presence of the other 2 legends here. Dr. Suparno, please come here, sir. Wonderful presentation, sir. I can understand that we had some legends today amongst us. I am not a pathologist. I couldn't understand much, but I understand that this is something very big in the making. That much I can understand as a bystander and as a very keen student of medicine. So I would ask my first moderator, Dr. M L Kalra sir, then I will go to Dr. Sarita ma'am, and then to my third moderator, Dr. A S Nigam sir. By no means it reflects their position in hierarchy, but just because it's the tradition. Sir, over to you. Please set the ball rolling.
Dear friends, we had a very nice talk, very rich talk, and some of the things were supracortical for us because we are not so much into hematology, but we could understand most of it. And meaning एक बारी और मिलना होगा. Sir, bone marrow transplant we were talking about. It's somewhat like blood transfusion, but not like exactly that. And it is somewhat like organ transplant, but not exactly that. So, we have in our group a very learned person who is doing work on stem cells, Dr. Ashish Verma. I will expect some questions from him in a short while. Sir, in your presentation, you were saying about T cells to be removed and to avoid some graft effect. So what about adding and combining CAR T cell therapy with bone marrow? Is it possible? Because then T cells are modified and reintroduced.
CAR T cells are, despite all the hype and publicity, are very much in the infancy. So CAR T cell, what you do is you sidestep or you completely bypass the nature's mechanism of how T cells kill the target cells, which is through engagement of the MHC dependent antigen presentation. Here you are introducing a missile onto the T cells by genetic engineering, where it directly goes and kills the antigen possessing T cells. So what has happened as a result of that, and I want everyone to understand this about CAR T cells because of so much hype that's created, especially by the government as well. So in the process of doing so, many people thought it's a clean process. It is autologous T cells. There is no graft-versus-host disease. You take one's own T cells, introduce into the patient's body. So CD19 is expressed by B cells. It is expressed by normal B cells, it is expressed by lymphoblastic lymphoma, it is expressed by lymphoblastic leukemia. So the T cells, when they are engaged to kill the CD19 possessing cells, will go and neatly clean those cells. But what happened was that in the process of doing so, it created a huge inflammation around it, which is called a cytokine release syndrome, which even kills people. It even requires ventilation. And more importantly, a number of patients would go on to develop certain neurological abnormalities called ICANS, immune effector associated a stem cell into another human being. It would have to have an HCN, to express an HCN. So there has to be a reaction.
So I'm talking of maybe in future, 100 years ahead, we are thinking about lab-grown meat, lab-grown milk without animals. So I'm just imagining, will it be some lab-grown bone marrow? Is it not?
As I said, I hope not, because if you are growing everything in the lab, we will be growing human beings in the lab at
Yes, sir. This is the next step. Sir, what about cadaveric bone marrow transplant? Is it in practice? Is it thought of, or is it not into?
Because in liver and kidney transplant and solid organ transplant, you do not require HLA matching. What you require is that the patient should not possess antibodies against the donor's HLAs. That's all you need, because you keep the person under immunosuppression forever. In bone marrow transplantation, you require bidirectional tolerance, which can only develop under certain circumstances which I will explain.
My last comment is on your CMV exposure for NK stimulation. So there are in pipelines even smallpox or senior virus also being used for immune health. Sir, my questions are here.
I give it to Dr. Savita Sachdeva ma'am for I'm sorry, I'm so sorry ma'am. I'm confused the name. Yes. I think it is because of the NK cells. So it's all the effect of the NK cells which have gone into my bone marrow. So ma'am, please. Yes, you're right. Please go ahead.
Thank you, Dr. Sarita and Dr. Chakraborti, for such a nice talk. And as we all know that for a bone marrow to be transplant to be successful, the two most important things are, for in general, like the two most important complications have to be handled in the infections and the graft versus host disease. And for this, the recent innovations which you are doing in your hospital will help us in great deal. I just want to ask, will this takes care of the acute graft versus host disease? Does this take care of the chronic graft versus host disease also?
Our intention is to prevent both these things, acute as well as chronic.
In malignant transplants, we wish we do not get chronic graft versus host disease, but we do not actively try to prevent it, because it's thought to be a part and parcel of preventing disease recurrence. In non-malignant disease, our full focus is on preventing both. So that's why abatacept is given for a prolonged period in non-malignant disease, whereas it's given only for the first 35 days in malignant disease.
Thank you, sir. And second is, how about the cord blood transplant? Is that any way better than if we don't get any relative transplant here?
So there are several things starting from the cord blood bank. So we don't have established public cord blood bank. We have the mostly private cord blood bank. Second thing about the cells, quality and the cryopreservation. So the number which will be required for the transplantation is not sufficient in the cord blood. Of course, people have been used and they are still using in some center. They might be few centers they are using double cord blood also. So these are the problems, specifically in India, the number of the cells and the viability. How much charge they take when they try to collect your cord? So it's hardly 35 to 50,000 rupees. But do they ever give you the viability after certain time period? So no one check it. And the person who is storing those cells, I don't think he or she will require in the future. So these are the problem with the cord blood. Of course, it's the certain centers in India, especially Dr. in Chennai, she was using this because there are several complications in the sense that engraftment, successful first step of transplantation is called engraftment. So intense earlier, if we are using a particular stem cell, we can say that the peripheral blood stem cells, and for cord blood it takes at least minimum of 20-25 days. So you have to keep these patients to successfully for 10 more days when the counts are 0, because you don't have any stem cells. When you're giving the conditionings, you have killed all the cells. So you have to make the patient survive over 20 to 25 days. So in that respect, the staying to the hospital will also prolong for another 10 days, and the blood product also. So the cost is also too high in that.
Because it has become quite a fashion from last 10 years.
Yes, to store, yes, many of the these private agencies come and they suggest or they even that store. So these are the problem, yes, but for this research purpose and at the same time the other component of those cord blood like mesenchymal cells which we are doing nowadays, so that can be used in that respect, not for the transplantation, for the same patient.
Thank you, Dr. Savita.
I would give it to Dr. A S Nigam sir to tell us and to make it little easy for lesser mortals like us who do not understand much of pathology, less of hematology, and least of healthy cells. Sir, with due regards to your great work, sir. Sir, please, sir, go ahead.
So, Dr. Suparno and Dr. Savita. Wonderful talk by both of you. And in fact, I remember first bone marrow transplant in India was in 1983 by Dr. Suresh Advani. Is it right? At Tata Memorial Hospital. And then, of course, Maman Chendi in Vellore and then in Delhi. They were also started, but first was there. So it was, I happened to attend his couple of lectures. Suresh Advani is in wheelchair and all. So I was remembering, and now again, wonderful talk by Dr. Suparno. So, to the basics of humanity. It was difficult for me to, after these many years, to. So that is number one. And now I would like to know, as you mentioned about grafting, if your graft fails, do you have a repeat transplant or what is
So if the graft fails, you have to look at the reason for failure. Today, for matched donor transplantation, graft failure is very good. Now, for heart match transplantation, graft failure still happens in 10% or more of patients. So what happens is, if a patient is heavily transfused, for example in thalassemia or aplastic anemia, they get lots of transfusions. The transfusions are unregulated, means they are not leukoreduced, for example. For everyone to know that anyone and everyone in today's day and age should receive leukoreduced blood transfusion, because it reduces the complications related to blood transfusions in the long term. It is said that if you do not leukoreduce transfusions, you increase the incidence of relapse in a cancer. So I'm just giving an example. But what happens in any individual, any immunocompetent individual is, if they receive non-leuko-reduced transfusion, which basically means that, Dr. gives me blood today. His HLAs and HLAs mismatched with me. I'm immunocompetent, so I will mount a reaction against his HLAs. And this is memory response. So this will stay with me forever. So if I am going to receive a bone marrow from him in the future, I am straight away going to reject it. These are called anti-HLA antibodies which develop from repeated blood transfusion. So the patients of thalassemia or aplastic anemia are likely to develop such antibodies, and when we are going to do a transplant from HLA mismatch transplant or half-match transplant, we have to make sure that they do not have such antibodies against the donor. So that is one cause. If we do so, if we don't do so and find that it's rejecting, what is that? The other is the cellular immune system, which we do not detect, we cannot detect in the given understanding or given repertoire we have, which is mediated by the T cells, not the B cells. So that still happens and that can still happen. So that is 10-15% of the patients will still reject. Now, there are two options if the graft rejects. You transplant from the same donor or you transplant from a different donor. In half-match transplants, we try to transplant from a different donor. Because it's immunological outcome. It is either B cells or T cells which have caused it. So to introduce the same HLS again, it has to be, the patient has to be again reconditioned in a very strong manner, which is difficult in a very proximal setup. Means once you have given conditioning, within 20 to 30 days of doing another strong conditioning, which makes it very low. So it's best to go for a second donor or a different.
Thank you. So, sir, how many transplants annually are being done in
We don't do a lot of transplants because we specialize in doing half-match transplants. So we sort of focus on around 4 transplants a month. I mean, that's the capacity we have. People can do any number of transplants, but ultimately depends whether you are achieving success in the number of transplants or not. Because there are centers with 10 beds, 15 beds, 20 beds, 30 beds even they claim, and they say we are doing 200, 300 transplants a year. But as a transplanter, I can tell you, I cannot focus on 20 transplants a month as an individual. It's not something like a surgery that I do and walk out of the OT. It requires constant vigilance. We are constantly keeping a vigil on our patients. So it's humanly impossible to do that many transplants with the same intensity, honesty, and purpose. So we don't try to do too many, we try to focus on doing the best we can for patients.
Just before I come to you, Dr. Chakraborti. Sir, what is the commonest indication for which you are doing bone marrow transplants?
As a center, we do most of our transplants for acute leukemia.
Which leukemia, sir?
Acute myeloid leukemia is number one indication in adults. And in children, it is thalassemia and acute lymphoblastic leukemia.
Sir, what is the prognosis of acute myeloid leukemia if we do not do a bone marrow transplant alone on chemotherapy?
See, there are a lot of, as I said, Newtonian laws of this applied in this condition, where it is said that if you have certain mutations, if you have certain cytogenetic combinations, you will go, there are certain you don't go, etc., etc. So going by that, 15% of patients will have favorable genetic risk factors in which you can get away without doing a transplant in 50% of the cases, for the rest
In 15%. 50%.
So basically 10% of AMLs you can get away without doing a transplant, in 90% that sounds
Right. Sir, are you doing bone marrow transplant for ALL also?
Yes, I mean, for children, those who are at high risk of relapse determined by their various prognostic factors at the outset. Otherwise, we do them in relapse.
All right. Sir, are you the only center which is working on this concept of
Yes.
So
we are the only center.
You are the only center?
Yes.
So, do we expect something very big, ma'am, in the years to come? I am not making any...
No, that's definitely, we have already reached to a certain platform and we will achieve something more importantly and good results.
How much has it added to the success of bone marrow transplant over other accepted therapies contemporary times?
Yeah. After the incorporation of a beta set in the 4 days back, we have shown we have compared our data with the other center in India as well, North India, where the half match transplantation published data was 20% success, and the CMC below, many doctors must be knowing that the haploidentical transplantation success rate is 45%, whereas our data is showing bone malignant cell is 90% and the 80% and the non-malignant is 86%.
Ma'am, I understood from Dr. Chakraborti's talk that things are different in solid organ transplant.
Yes.
So this concept, it does not work in solid organ transplant?
Yes, this beta set, the concept started from the rejection in the solid organ transplantation of a beta set. That is why they have thrown this beta set, as when Dr. Chakraborti has explained. And why? Because they are not affecting NK cells, and they thought this rejection is because of the distant to NK cell, and that negative concept we have taken and we have brought in our transplantation, that we want to establish the NK cell mediated dose, the reduced incidence of relapse, the GVHD prevention, and so that's how we have incorporated this.
Ma'am, on behalf of the forum, we would like to congratulate your center, Dr. Chakraborti's innovative work, and for you to carry forward the legacy. We wish you all the best. I'll go to Dr. Chakraborti sir for his question.
Thank you, Dr. Johnson. Well done, sir. We are proud of you, at least for once. The best has looked forward to us and complimented you for your work. That's a very great moment for all of us, the Indians. We are proud of it. Thank you so much. I have two questions, ma'am. Number one, since we see quite a few cases of thalassemia, what's the youngest age would you go for organ transplant, number one? And number two, what is the ideal donor for, whether the mother, father, or the siblings, number one? Number two, there's a great fashion for nowadays, a baby is born, and the hospital people can go for the corner. This thing. These are two questions. Please clarify yourself.
For your question, I think I have to restart my presentation, which I gave 4 days back. So starting from the beginning, what age group we would prefer to do transplantation after 2 years. So yes. So what is the age group? 7 years is the best ideal time period where one should go for transplantation. And as early is the better, because of the repeated blood transfusion, patient have iron overload, and that is the main culprit for the prevention of successful outcome. Yes. So ideal donor oppose the matched sibling donor in the where the results has shown that more than 90% of donors survival. But you have to remember the family in a nuclear family when one's kid is thalassemia. So obviously patients are a bit skeptical or scared to take to conceive the other child. And most of the families we have seen in India, they have only one kid. So in that situation, finding a matched sibling donor is very difficult. So that is how the concept of half match transplantation has come. And as I have shown to you that there are several criteria of choosing a best eligible donor, and then we decide amongst parents, we have to decide. So there are several factors which we might discuss in the subsequent.
Dr. Sarat Gopalan, Dr. Sarat Gopalan.
Load of cord blood, yes. No, not controversial. If really the matched sibling cord blood transplantation you can proceed with. That's the only thing.
Dr. Sarat Gopalan is a pediatric gastroenterologist.
Dr. Suparno and Rani, thank you again night before. Thank you again for a wonderful presentation. But my question is a very basic question for general physicians as well as pediatricians, not only specialists like me. Chemotherapy versus immunotherapy, is there a distinction? Because all chemotherapeutic agents in malignancy have an immunosuppression. So why do we use the word immunotherapy? So what are the specific immunotherapeutic agents which are distinct from chemotherapy? Second thing is, when it comes to pediatrics, you mentioned ALL and thalassemia. I presume ALL is much more common compared to thalassemia. Am I right? Thank you.
Immunotherapy versus chemotherapy, sir.
It's a wonderful question because it's absolutely basic. See, if I have 2 minutes, I'll start from the beginning. That why do we get cancer? What is our current understanding? So let's take the example of lung cancer. So where we know there is an established carcinogen. So I'm smoking, I'm inhaling some 80 carcinogens at a carcinogenic dose 10 times a day, and I should develop it. It should be non-controversial, unequivocal, but not every smoker develops cancer. So why doesn't an individual cell which is regularly exposed to carcinogen not develop cancer? Because whenever we are exposed to carcinogens or mutagens, the cells undergo carcinogenic change, which basically means that it loses homeostatic control. So when a cell loses homeostatic control, it expresses itself in a bizarre manner. Like, I can recognize that you are unhappy by looking at your face. So the immune cells similarly recognize rogue cells by looking at them by expression of certain antigens on the surface, by loss of certain antigens on the surface, and so on and so forth. So they are constantly surveilling in our body. As I said, the T cells are constantly in circulation. NK cells are constantly in circulation. There are T cells and NK cells which are called resident T cells, resident NK cells, means they stay in that particular organ. So these are the huge amount of sentinel surveillance that's going on in the human body constantly. That's why we don't develop cancers. But the moment the cancer cell is clever enough to trick the immune cells, or the immune cells are tired, or they are old, or they have been tricked by the cancer cell, cancer develops. So once that develops into a full-blown disease in solid organ cancers, you have to cut it out very simply. Because it forms a gola. You have the opportunity to cut it out with the covering, this, that and everything. But you know that even then, today we know, even before we knew that that was not enough. That's why we have to keep on giving chemo and radiation after treating the surgically the cancer. So after surgically taking out the we still have to give chemo and radiation to eliminate whatever has been spilled out elsewhere. But what happens when they are not amenable to surgery, like in blood cancer? At that point of time, when there is, so the number of cancer cells at a given point of time when you have a full-blown leukemia is 10 billion. 10 billion. So at that point, you don't consider about the immune system. You are go for a kill. So when you have 2 or 3 Hezbollah come into the country, you try to track them. Not killing the villagers. You are trying to fish them out. But when you have thousands of them coming, you can't bother about them. You have to blast the village to save the rest of the country. So that is what chemotherapy is.
Wonderfully explained, sir. Wonderfully explained.
So once we have done that, then we focus on the immune system.
So why don't you start taking some basic classes for physicians? Honestly speaking, Dr. Chakraborti, I mean, you are a great teacher, sir. Absolutely fantastic. Dr. Padar, sir.
So, Dr. Chakraborti, what I have understood is they are normal cells, maybe T cells, they are able to kill the tumor cells, cancer cells. But when cancer develops, that our killer cells are not able to differentiate between cancer cells and normal cells, and so immunotherapy helps again those cells to identify the cancer cells, and then they again our normal cells will kill cancer cells. Is it right?
So what happens is that there are 2 things that happen. I'll take the example of T cells. So whether it's a cancer or a chronic infection. So cancer is equivalent to chronic infection. Okay? Hepatitis C, HIV, chronic hepatitis B, or tuberculosis. What happens? Why can't we eradicate them? It's because when we first meet the particular virus or the bacteria, we attack them. But these viruses or bacteria, which are very similar to cancer cells in their behavior, they learn to evade, they learn to escape.
Mingle with the normal cells.
They learn to avoid the T cells one way or the other. So that T cells keep on attacking, Now, in this process, there are 2 pains for T cells. It is called activation-induced death. Now, you get too activated, the T cells die. So, body has got a mechanism in place. Beautiful. What is it? So, when a T cell gets too activated, it says you have done too much job, no rest. It's called exhaustion. So there are certain markers called PD-1 which are overexpressed in these T cells, which means that these T cells now cannot attack the cancer cells, because cancer cells express the ligands for these receptors. So when the T cells bind to the cancer cells or try to attack the cancer cells, this binding now inhibits the T cells. They sit quietly even though they see the cancer next to them. This is called a process called exhaustion. Now these exhausted T cells are not dead T cells. This is nature's way of preserving the army which are able to attack, which are trained to attack the enemy, but they are too tired. So keep them in hibernation. So this James Allison discovered this in the 1970s, and the modern immunotherapy is based on this concept that you have drugs now which bind to PD1 and do not allow the PD1 receptor to bind to the cancer cells. So they are removing the exhaustion.
Dr. Sajid.
One minute. That was many immunotherapy given when PD1 is high. When we do on
PD1 is high. Yeah.
then we give many immunotherapy.
Yes.
Sir, Dr. Sajid is feeling very proud of your team, sir, today. A simple thing, sir. One of my patients, elastic anemia, 6-year-old child, he is getting treatment from AIMS, multiple transfusions. Do I have a hope for him? Because they are waiting for her sister to grow up to be a donor for him. And that will take time. She is just 3-year-old, maybe they are waiting. So, is there a hope of, like you said, there is it's not necessary to have a similar sibling donor. It may be that any other member of the family can give. Number one, and number two, what will be the cost? Because they won't be able to. Will they be able to afford? They are getting treatment from AIMS. Now they will come into a private hospital setup. What can be the burden to the family? I mean, just these two things.
It's a wonderful question. It's a story of opportunity lost. Aplastic anemia in children is considered as an emergency transplant. It's like a road traffic accident. So you have broken the neck of femur, you have to do a surgery right there. You cannot leave it unplastered without a surgery and expect to heal later on. So what happens, and we see day in and day out, especially unfortunately from these government institutes, they are just transfused. As I just explained, more transfusion, more chance of rejection. So what we do in a given situation, if the 6-year-old had come to us, we would have done a transplant from either parent, half-match transplant. The success rate from us and a few others across the country right now is in excess of 90%. For aplastic anemia with haploidentical transplant. There is no question of a child has to grow up or anything. I mean, this is an emergency situation. You have to do a transplant.
That is why I had a hope today.
The cost, if you can do an upfront transplant, can be as little as 15 lakhs.
Now, sir, at this stage, with multiple transfusions,
we have to assess whether the patient is even fit to receive a transplant from the parents. Because there might be too much of HLA antibodies. Now we desensitize these patients, which takes a lot of time, a lot of money. So cost is an escalating thing. The sooner you intervene in the right manner, the lesser the cost, irrespective of whether you have money or not.
Sir, Dr. Jitendra Saxena, his brother is oncologist, Dr. B.K. Saxena.
Sir, do you also do bone marrow transplants for thrombocytosis like very high platelets count?
Bone marrow transplantation is reserved for situations where the condition is such that life is not compatible with that particular condition. If life is compatible, means if you have very high platelet count by itself, you can bring the platelet count down by hydroxyurea, give aspirin, etc. It's called essential thrombocythemia, the pathological condition. Only when this turns into a malignant clone, means it can develop into a myelofibrosis or acute myeloid leukemia, will do a transplant. But for thrombocythemia or essential thrombocytosis per se, we will not.
Even if there is a risk of DVT or life-threatening conditions?
No, we will do the underlying condition because bone marrow transplantation has got an inherent risk of mortality of 10%, at the given point of time. So only when the risk, the benefit is outweighing the risk, we will do it.
Sir, the younger student from the group, Dr. H L Kanpur, sir.
When you are giving this DMT, you are giving this abiraterone plus DLI, donor lymphocyte infusion. Sir, my question is how many you are giving only once or it is repeated, and what is the QR rate? Number one. Number 2, are you giving progenitor by myeloid series cells also along with these stem cells? Here is something which is not coming in my mind. I should just clarity about it.
Brilliant question actually, because when we give a graft, it's something we tell the students, we tell everyone that when we are giving a bone marrow graft, when we are giving a peripheral blood stem cell graft, less than 1% of the cells are actually hematopoietic stem cells. 99% of cells are other cells. 60% are T cells, 5 to 10% are NK cells, 1 to 2% are gamma delta T cells, some 0.8% are myeloid suppressor dendritic cells. There would be 0.0% dendritic cells, and there will be neutrophils and monocytes which do not live with the system for very long because they will die in due course. I am talking of the living cells which are going to survive for weeks and months. They are mostly of the lymphoid lineage. Of the myeloid lineage, they are the dendritic cells, monocyte-derived macrophages who are going to remain in the system, and they comprise 99% of the cells. So stem cells are 1% or less than 1%. And out of that, it's very interesting, only 2 to 3% of those cells are actually going to engraft in the bone marrow. And they are going to sustain life. And the amount of stem cells